Hello and welcome back to M.Hook's Respiratory System Part 2. So in Part 1 we started going through the respiratory anatomical structures and we got through the trachea to its branches. So we're going to go through the bronchial tree, this dividing of smaller and smaller tunnel systems that get all the way to the ends of our lungs, to the ends of our respiratory system. So the first branch off of your trachea are the right and left primary bronchi. Each of those goes to a lung. The right to the right lung, the left to the left lung. Right? And they branch into the lung right at the hilum of the lung, and that's this indentation. You'll generally see hilums whenever you have structures entering and exiting organs. And after that first branching, you'll have your second, so that'll be the secondary. That's called your lobar bronchi, or bronchi. That's one branch to each lobe. Your left lung has 2 lobes. There's less space there. You've got a cardiac notch for the heart. And the right has 3. Each of those lobar branches, the third branching you have, the tertiary, is segmental bronchi. And that goes to each bronchopulmonary segment. We've got a really good view of that later in the chapter. And as we branch, we see these changes occurring. The branches get smaller and smaller until they get really small, less than 1 millimeter in diameter. Those are bronchioles. And then at the end of the bronchioles, you have terminal bronchioles, less than 0.5 millimeter. Very, very tiny. And then those will go into the alveolar ducts, into the alveoli. At our terminal bronchioles, we're going to start having some respiration occur. So there we're going to be switching from the conducting zones into our respiratory zones. That whole portion we just covered in the first video and the beginning of this video were the conducting zone structures. Finally, near the end of our respiratory tract, we're getting into the respiratory zone. And this shows the bronchopulmonary segments. Each of those colors is where one of the tertiary or segmental bronchi leads to. And then here you can see this nice breakdown from primary, secondary, tertiary, branching 20 more times until you get to the bronchioles and terminal bronchioles. Okay. So large, more macroscopic structure of the lungs. You've got the apex of your lungs is the top, it's the tip. The base is the bottom where it's more broad. Remember, in the heart, the apex was the bottom because it was a point, and the top was the base. This is switched. Apex is always the point. Base, think of a mountain, it's always the widest portion. As we discussed before, the hilum is where you have the entry and exit of the bronchi, your blood vessels, lymphatic and nerves. And your left lung is smaller than the right. It's got more space for the heart. It's got this cardiac notch there that we'll look at. And the left lungs, because you have 2 lobes, there's only one space that divides them. Anywhere you have lobes getting separated, they are called fissures, these deep grooves between the lobes. Your top lobe is called the superior, the bottom the inferior, and the fissure between them is slightly diagonal, so it's called an oblique fissure. There you can see superior, inferior, oblique fissure. Whereas on the right side we have 3 lobes, superior, middle, inferior, and the top, more superior fissure goes more flat straight across, so that's called the horizontal fissure. Whereas the right lower portion is diagonal, so that's the horizontal fissure. And there you can see the cardiac notch, the trachea leading in and the branches, the diaphragm on the bottom that the lungs rest on. That will contract to change the amount of space in your thoracic cavity. Around the outside of your lungs you have serous membrane. So remember, around the heart it's the pericardium, around the lungs it's the pleura. So you've got the visceral layer touching your lungs, serous fluid in the middle, and the parietal layer touching the wall of the cavity. The serous membrane here is going to be important for several reasons. It's going to help reduce frictions as the lungs expand and contract, as well as provide this low pressure area to allow the lungs to expand more easily. And we'll look at that more when we talk about pressures. As already discussed, we've got different fissures separating the lobes, more horizontal and oblique. Right side has 3 lobes, left side has 2 with only an oblique. And what you see in the tissue in the histology of our branches of this tree, as we get smaller, you'll see the cartilage rings that make sure things keep open get more irregular, and you'll have more elastic fibers. You'll also see the amount of smooth muscle increasing. That's because now we want to be able to control where the air flows, getting more oxygen in the areas where we have better blood flow, opening up so we can get more carbon dioxide out of areas that have more carbon dioxide. Now let's get more into the respiratory zone. So we've got those terminal bronchioles, and then those go down to the respiratory bronchioles where we start, the gas exchange, oxygen going from the air into our blood, carbon dioxide from the blood into the air. And then you'll have alveolar ducts to these alveoli. They're clusters of little grapes, basically. The whole grape structure is an alveolar sac. Each individual grape is an alveoli. Does that make sense? And the reason that we have alveoli is to increase surface area. We've got this single layer of tissue for gas exchange, and the more circles that we have, the more surface area we have for gas exchange, which allows us to get more oxygen in, more carbon dioxide out of our blood to be more efficient. If you took all your lung tissue and spread it out, it could cover tennis courts. And so you can trace here from terminal bronchioles to respiratory, alveolar ducts, alveolar sacs, and alveoli. That's where we have the gas exchange occurring. And there are the alveoli. Lining the alveoli, you have 2 types of cells. Most commonly, you have these simple squamous epithelial cells, or alveolar type 1 cells. They're really flat. They're really flat so that gases have less distance to cross, so they can diffuse really fast. If they were too thick, we wouldn't be able to get enough oxygen in. Some of the alveolar cells are called alveolar type 2 cells, and those are these cuboidal cells, more square-like. Those make an important product called surfactant. That's going to be important during breathing to allow our lungs to stop from collapsing every time we send air out. So here you can see we'll have deoxygenated blood coming in through the pulmonary arteries, going away from the heart. Capillaries getting oxygenated, and when blood goes through the pulmonary veins, they're going to head back to the heart to get sent out to the body. And then on the outside of the capillaries, you've got these elastic fibers to allow for stretch. You can see the smooth muscle on the respiratory bronchial and alveolar ducts to allow for contraction. And then between the alveoli, you've got these holes, or these pores. That makes sure that we equalize pressure throughout the lung. Otherwise, you might have some alveoli under really high pressure, and some very little pressure, they might be collapsed. And then wandering the surface of the alveoli, you've got alveolar macrophages. So those are the big eaters. They come by, eat as much as they can before they die. They take in and break down lots of foreign materials that have made it down into the lungs. And then the ciliary lining of our respiratory tract is going to move it back up the bronchi, up the trachea, past the larynx, and we swallow it. So there's the alveolar pores, the type 1 alveolar cells, the type 2, the square making surfactant, and the macrophages wandering the surface. And here you can see that single layer of thin cells lining the alveoli and lining the blood vessel, the capillary there, to make this thin surface where gas is diffused through. So blood supply. There are two routes of circulation for blood flow to and from your lungs. There's the pulmonary arteries and veins, and that's coming off of our right side of our heart. Deoxygenated blood coming in, getting oxygenated, going back to the left side of the heart. But not all the tissue of the lungs can get enough oxygen through diffusion. So anything that's further away from blood flow, like the bronchi and their smooth muscle around it, they'll need direct blood flow. So coming off of the left side of the heart, the systemic circuit, you'll have the bronchial arteries. So that'll get all the lung tissue that needs oxygen, the oxygen it needs. And that branches off the aorta, goes into the lungs. Next, we're moving into our physiology. We've got all the anatomy covered. We're ready to look at how it works, how we inspire, how we breathe in gases, how we breathe them out, how they move through our blood, how we totally function. Okay? So we'll start out with the first process of respiration, pulmonary ventilation. Inspiration, inhaling, expiration, exhaling. And that's going to have to do with the pressure in our thoracic cavity, how the diaphragm and our intercostals are moving. So there you can see when we inhale, our diaphragm relaxes down, our external intercostals pull up, it makes a really big space. And when we exhale, we're making the space really small. So the diaphragm relaxes up, the internal intercostals pull down, and our external obliques and rectus abdominis contract, making the space really small. And there you can see when we exhale, the diaphragm is relaxed and up. When we inhale, it's contracted and down. And we'll go into why that makes sense. How air moves is dependent on its pressure. Everything moves from high pressure to low. So when we breathe in and out, we're changing the amount of pressure in our lungs, in our thoracic cavity, compared to the outside. The outside pressure is called the atmospheric pressure, PATM. And dependent on where you're at elevation-wise, it'll change a little bit. But at sea level, it's 760 millimeters mercury, or that's called 1 ATM, 1 atmosphere. So the pressure in our lungs is either going to be lower than that, greater than that, or equal. And that's going to determine how air flows. The intrapulmonary pressure, PPUL, is the pressure in our alveoli. This is what we're changing to make air flow in and out. So it's going to keep going above the outside temperature, equal, below, equal, above. Each time we breathe, it's going to change. The other pressure that's important is our intrapleural pressure, PIP, and that's in your serous membrane in the pleura. We always want this to be negative. We always want it to be lower than the outside and in our lungs. And think about it. If the serous membrane pressure is too high, it's going to push on the lungs and they could collapse. And normally it is going to be low, but reasons that it would be high, you could have fluid in there, swelling. If your lymphatics aren't pulling it out, they could cause your lungs to collapse. Okay. So here in this first picture, the pressures are equal. If they're equal, there's no net movement. In this second one, during inhalation, the pressure's lower in your lungs, higher outside. So it moves from high to low, moving in. And as we discussed before, if your intrapleural pressure is too high, the lungs collapse. And the difference in pressure between the pressure in your lungs and the pressure in the serous membrane is your transpulmonary pressure. If the pressure in your lungs is much greater than in your serous membrane, your lungs are bigger. It's easier for them to contract and expand. So what I would do next is I would tell my students a list of values for the different pressures and ask them what's happening in each scenario. In the scenario that we have up here, our atmospheric pressure is 760. Our intrapulmonary pressure, the pressure in our lungs, is 760. Those are equal. And here in our transpulmonary pressure, it's 4 because our interpleural pressure is 756. So we feel pretty good about this. As long as our interpleural pressure is lower than intrapulmonary, our lungs aren't collapsing, we're good. So we don't have to worry about this. Comparing these two, they're equal, so I wouldn't expect any net movement of air. If the intrapulmonary pressure was 764, the pressure in our lungs would be high compared to the pressure outside would be lower. Air would move out. We would be exhaling. If the intrapleural pressure was 764, our lungs would be collapsed. So lung collapse is atelectasis. If you have your bronchioles plugged with mucus, for example, they collapse. You can have a pneumothorax, air in your pleural cavity. If you get stabbed, if you get air in there, you're going to have more pressure. So to reinflate your lungs, you'll have to remove that air with tubes before the lungs can reinflate. Okay, so we've discussed how we have different pressures and how that makes air move, but we haven't seen what we do to change the pressure. And what we do is we change the volume. Volume and pressure are very related. And you can see that with Boyle's law. So Boyle's law is pressure 1, volume 1 equals pressure 2, volume 2. And let's look at this example to see what that means. Okay, so we have this space. We have 1 liter of fluid of volume for our air molecules to move in. If we push this piston down and we give them half the space, their pressure is going to be twice as great. The molecules are going to be hitting each other more. They're going to be coming in contact with the side. It's going to be higher pressure. So that's what we mean by varies inversely. If you decrease a volume, the pressure increases. Inversely means they are oppositely related. If you increase the volume, the pressure decreases. As one goes up, the other goes down. So we change the volume of our thoracic cavity to change the pressure there. Okay. Now let's look at those factors that affect us bringing air in and out. What, other than changing the pressure, can alter how air is moving? First, airway resistance, or friction, our alveolar surface tension, and our lung compliance, how stretchy they are. So the first is resistance. Just like in blood flow, it has to do with friction. So anytime you've got less space, there's going to be more friction. Less space means molecules are going to be hitting each other and the walls more. And as you can see by this equation, as you increase resistance, your flow is going to decrease. This generally won't be an issue unless you have something else going on. If you've got a lot of mucus plugging your airways, if you have a severe obstruction or constriction. Constriction could be due to asthma attacks or allergies. And then what you would want to do is you'd want to give somebody epinephrine. Epinephrine dilates bronchioles. It makes them bigger. It reduces the resistance. So same idea as blood vessels. If you dilate the blood vessel, there's less resistance. It's bigger. Okay. The next factor of ventilation is surface tension. So what happens to water molecules is they're all attracted together. They have those hydrogen bonds, these weak attractions between molecules. The partial negative of the oxygen and the partial positive of the hydrogen of molecules are attracted to each other, and so they want to come together. So what happens when you breathe out and you're not making surfactant is the alveoli would collapse. This is what happens in prematurely born newborns who aren't making their own surfactant yet. In a normal child or adult's lungs, their alveolar type 2 cells make surfactant, and what that does is it breaks those water bonds. It reduces the surface tension. It basically acts as a detergent and breaks them up. In premature infants, that's called infant respiratory distress syndrome. So generally they'll have to have them on a ventilator so that their lungs don't collapse and they don't have to work as hard to breathe. And last, lung compliance is how stretchy your lungs are, how easily they expand and retract. So a higher compliance means they expand more easily. They change size more easily. If somebody has a compliant personality, they're willing to change their views more easily. So higher compliance, they stretch and recoil. If you have scar tissue, you're not making enough surfactant, you've got fat in there, or your thoracic cage just isn't as flexible, you're not going to be able to expand and recoil your lungs as easily. So that would make it harder to breathe in and out. And this is the end of part 2 of our lecture. We'll continue in part 3. Hope to see you there.